in this talk, I'll speak about the generalist's role from a cardiologist perspective. So many of our children with congenital heart disease obviously receive very frequent and intensive subspecialty care, and so there's always the question of what is the role of the general practitioner. So with regard to background, more children with congenital heart disease survive and are discharged from the hospital now than ever before. These patients have complex healthcare needs that can be, however, provided for and coordinated by their primary care provider. So what is the role of the primary care physician? And really, I think it's to be the medical home for these children. But the question always comes up for that primary care provider, what's too much and what's not enough? So I think the role of the primary care physician is going to differ at different stages of the child's life. And we can think about the prenatal and neonatal period, infancy, childhood, and then adolescence. And the role probably has the most importance at the transition times of the child's life. And those biggest transition times are probably infancy, where there's transition of the baby from sometimes prolonged hospitalization to home for the first time. And then again in late adolescence and early adulthood, when there's transition from pediatric to adult medicine care. So during the prenatal and neonatal period, the role of the primary care physician sometimes is going to be somewhat limited, with the majority of the counseling and coordination provided by maternal fetal medicine, pediatric and fetal cardiology, and the neonatal intensive care unit teams. The primary care provider, however, can offer parental support, especially if it's parents that he or she already knows because of care of a sibling. And then can offer a role for coordination of care if that role is not handled by neonatal or pediatric cardiology. That could include things like genetic screening, coordination of other subspecialists, and anticipation of non-cardiac issues and other organ involvement. Infancy, particularly related to care after hospital discharge, is probably one of the most important times where a primary care physician can get involved. And so it's of extreme importance that we have a coordinated transition of care from the hospital to the primary care provider. And obviously that falls on us as the providers in the hospital to help coordinate this care. I think ideally this should include the cardiac diagnosis, a list of completed or planned interventions, as well as residual defects, any other organ system involvement that there is, a discharge physical exam, including particularly weight, oxygen requirement, and baseline saturations, and then feeding regimens and home medications, including anticoagulation if applicable. Ideally, we try to do this through a call to the primary care provider prior to discharge of the baby from the hospital. Obviously, if that's not feasible, some type of written transfer tool or discharge summary can suffice. Nutrition and feeding are very important in infancy and can have participation of the primary care team. It's a common challenge, as we discussed, in many of the children with congenital heart disease, particularly in infants who have pulmonary overcirculation, too much pulmonary blood flow, and those who have undergone newborn heart operations, especially the Norwood procedure. Many of these babies are going to need 120 to 150 kilocalories per kilo per day to achieve adequate growth, and calorie fortification is often necessary. Many of them have limited oral intake ability for a variety of reasons, including heart failure, suck and swallow incoordination, post-op vocal cord injury, airway, and structural or functional neurologic abnormalities. And for a lot of these children, either a nasogastric tube or a G-tube may be necessary. Other GI issues or complications can be ongoing as well, including GE reflux, aspiration risk, osmotic diarrhea, potentially from high-calorie formula, constipation, and consequences of improperly mixed formula. In infancy, as well as throughout the rest of childhood, there's a need sometimes for special immunizations as well as infection issues. So the primary care doctor can help prevent, identify, and manage infections in these children with congenital heart disease. And I think often this is a specific role of the primary care doctor. We usually rely on primary care physicians to do the actual immunization, administration, and management. And I wanted to point out that current, recent, or upcoming anesthesia or surgery is usually not a contraindication for immunization. Those that involve cardiopulmonary bypass, we may not want immunizations for the week or two just prior to make sure that immune complexes are not removed. And then the ability to mount an immune response after bypass also might be limited, so we generally advise waiting 2 weeks. But the risk sort of and benefit ratio of the immunization versus the risks that the immune response won't be mounted need to be taken into consideration. And then there's some special categories of immunizations as well, including Synagis or the RSV protection for high-risk infants, as well as those children who have heterotaxy that can be associated with asplenia or sometimes with polysplenia, but the spleens are often non-functional. Those children need follow-up pneumococcal vaccines as well as daily amoxicillin prophylaxis. And then there's the important role of endocarditis prevention and prophylaxis. So often this is primarily taken care of by the cardiologist, but I think that continued education and reminders by the primary care physician with regard to the reminding and the education is also important, as well as providing reminders to get good dental hygiene and routine dental care. So also, once we get to childhood, neurodevelopment and behavior issues become a concern that usually find their medical home in the primary care physician's office. As we've discussed, there's a higher rate of neurodevelopmental issues in children, especially with complex congenital heart disease. There can be higher rates of psychological maladjustment due to low self-esteem. And these issues are thought to be multifactorial, including sometimes related to the heart disease itself, perhaps related to injury during early episodes of shock or hypoxemia. There may be genetic issues in up to 30% of the children, as we've discussed, and then a whole host of other issues that may affect these, including prematurity, prolonged hospitalization, cardiopulmonary bypass, and other factors. The primary care providers should provide careful developmental and behavioral surveillance and screening for these children, really throughout the child's life, with ongoing assessment of academic progress. We generally recommend early referrals to mental health providers, therapists, and prompt treatment. And the primary care physician can facilitate help in school, including development of IEPs and 504 plans. Other issues in childhood and as well as adolescence include exercise and sports participation. So in general, cardiovascular health will be enhanced in virtually all children with congenital heart disease by avoiding a sedentary lifestyle, obesity, and hypertension. And studies of rehabilitation and conditioning programs, even for patients with congenital heart disease, have generally revealed benefits. So the question always is, though, how much sports? So in general, I think children who have normal ventricular function and no significant residual lesions, so their heart is mostly corrected or left only with a very mild, perhaps valve issue, generally restrictions are not necessary, and in fact, exercise prescription rather than restriction is actually the move. There are certainly a category of high-risk patients, and those include some of the patients that we talked about with regard to being high risk for pregnancy, including those with single ventricle hearts, with severe ventricular outflow tract obstruction, so aortic or pulmonic stenosis, hypertrophic cardiomyopathy, congestive heart failure, coronary insufficiency, significant pulmonary hypertension, severe untreated systemic hypertension, Marfan syndrome with aortic dilation, or exercise-induced arrhythmias and long QT syndrome. It's not that these children absolutely cannot participate in exercise. However, they generally need individualized recommendations and sometimes some restrictions. And so I think these are the category of patients in which collaboration with the cardiologist is essential. But it is important that we be careful not to give conflicting advice to the parents. Childhood is also sometimes a time of non-cardiac surgery. Up to 40% of children with congenital heart disease require some type of non-cardiac surgery by 5 years of age. So it's a lot. The benefits from careful evaluation, which is multidisciplinary, to plan input from the primary care provider, the cardiologist, the anesthesiologist, and the surgeon is probably the best way to minimize the risk of adverse events. And there is a higher risk of perioperative morbidity, again, in a small group of children who have severe heart defects, have continued cyanosis, have pulmonary hypertension, or congestive heart failure. Obesity is also an issue in childhood and adolescence. Patients with congenital heart disease, unfortunately, are not immune to the growing trend of obesity and inactivity in North America. The etiology is probably multifactorial, including poor nutritional choices and genetic issues, similar to everybody else in the population, but also may come about because of physical activity from perceived handicap or inability to participate in sports, which sometimes is the offshoot of sort of vulnerable child syndrome, even if families are sometimes counseled that it's okay to continue with exercise, they limit the child nonetheless. And the primary care provider can provide activity recommendations and nutritional counseling. Adolescence is a time where there's a need for risk assessment and risk reduction, again, similar to the general population, engaging the child or the adolescents in increasing responsibility for their own health, healthcare participation, self-advocacy, some of the same things that are faced by any adolescent. Same thing, risks that occur in teenagers without congenital heart disease occur in teenagers with congenital heart disease as well, and the primary care provider can provide a role in counseling of these young adults. As we mentioned, adolescence becomes a time of transition of care, and we're going to speak a little bit more about this later. But successful transition to adult care is a multidisciplinary process. It needs to begin in the teenage years, and the medical home or the primary care provider really should be able to facilitate the process to ensure a timely and appropriate conclusion of pediatric relationships and a shift from childhood dependence to adult responsibility. Older teenagers and young adults are often lost to follow-up during this period of time, and they have a higher incidence of unplanned hospital admissions through the emergency room, and gaps in care and cardiac care are felt to be linked to increase in morbidity. So key takeaways: patients with congenital heart disease and their families have multiple needs. A primary care physician can provide a medical home for these patients and coordinate multiple aspects of their care. Care coordination and communication among the family, the primary care physician, and the subspecialist is of utmost importance, especially among the transition times such as infancy, hospital to home, and adolescence, pediatric to adult care. The medical home can facilitate things like the nutritional support, immunizations, other organ involvement in care that's needed, and promote a healthy lifestyle, including nutrition and physical activity recommendations. Recognizing that there are a subgroup of congenital heart disease patients who are at high risk for morbidity from things like non-cardiac surgery, sports participation, and pregnancy, and this group tends to be the same group for all of those issues. Anybody interested in some further reading? This is a nice paper in the journal Pediatrics, and I'll end with that.